And I shall now welcome Elias. Elias is a relative to most people, a relatively new joiner to Berry Consultants, although that's a couple of years now, or over a year certainly. And Elias has been contributing to the development of FACTS and also doing some consultancy, helping people design some trials. So Elias is going to talk a little bit about that experience, although he's going to do it in an anonymized way and not talk about the actual details of the trial that he worked on. So Elias, without any further ado, would you like to talk about dose escalation and using open enrollment?
Yes, I would. Thank you, Tom, for the introduction. Thanks, everyone, for being on. I have the pleasure today to talk about CRM in FACTS, which, as Tom mentioned, is a topic that I have been involved in twofold over the last year or so. So both on the development side of FACTS, but also on the consulting side, actually designing trials using CRM and using FACTS. As a brief outline for this webinar today, I'll start off by generally motivating why we're doing this CRM open enrollment dose escalation study. I'll briefly say something about the basics of CRM, talk a bit more about advanced adaptations to CRM, all of which are possible in FACTS, of course. Then the actual process of setting up the design in FACTS and running the simulations, having a look at some of the results and interpreting them and discussing what the next steps would be if we were actually designing this trial, and then giving a summary of the webinar and of everything that was covered today. Okay, so let's start off by the motivating example. So just to mention here that the design that I'm going to discuss in this presentation is fictitious, but it's based on learnings from actual trials that Berry Consultants has designed. Let's assume we're in a scenario where we want to do a first-in-human study of any novel compound, and we also presume that we're in a situation where animal data and first PK/PD data already exists. We supposed to be in a situation where we're preparing for an IND submission, and we want to keep in mind Project Optimus. So we don't only want to learn about the maximum tolerated dose, but we also want to learn about efficacy and therefore something like an optimal dose as soon as possible and ideally seamlessly. So here, of this motivating example, these are some general design requirements that we might have in this situation. Again, this might be a result of the particular indication. So we assume that maybe we're working with a team that's coming from doing mainly 3+3 designs. And coming from 3+3 designs, people generally feel comfortable not exposing more than 3 trial participants simultaneously to a new dose level. So by simultaneously, I mean, say, this might be just a cohort size of 3. So we're at any given dose level and we assign 3 patients, we're waiting for their results, and then we sort of decide what to do next. Then if the model, so the CRM model, if the model permits, we would be ready to escalate after we have data of 3 completers. Let's presume we're starting at 100 milligrams and that we're interested in the dose range from 100 milligrams to 350 milligrams. And suppose the formulation is in such a way that we can escalate in 25 milligram steps. We assume to have a maximum sample size to determine the MTD of 60. So this would be the phase 1 part. And then, so this is in italic here. So let's assume we would have another 30 trial participants to also determine efficacy. So this could be a phase 2A part. We could do this in FACTS, and we would do this in FACTS, but seeing as there's a lot of materials already going to be covered in this webinar, I'm not going to talk about this particular part today, but this might be material for a webinar in the future. Let's see. We assume that the DLT observation period is 14 days. We're targeting a toxicity level of 30%. And initial pharmacological data that we have might suggest that the minimally effective dose could be somewhere around 175 milligrams. And you will know later why this is important. Okay, so let's just take a step back and let's talk about the basics of CRM for those who are not familiar with CRM, or just as a refresher for those that are. CRM is the abbreviation for continual reassessment method, and what that means is it's a model-based escalation method as opposed to a rule-based dose escalation method, where we're using all of the available data to estimate the dose toxicity relationship and sort of guide our decisions about escalation. What does that mean? So in 3+3, we might have fixed rules, such as if there's 0 out of 3 DLTs, then escalate, or if there's 3 out of 3 DLTs, then de-escalate, things like that. And that is sort of agnostic of the dose level that we're on, and that's also sort of agnostic to what has happened before in the trial. So that it might work well in certain situations, but one could also argue that it's a bit wasteful to sort of not include all the data that we've actually collected in the trial, and that's where CRM comes in. And since this is a model-based dose escalation method, we're assuming a parametric model, an underlying parametric model for the dose toxicity relationship. And there's several different models that we could choose. There's hyperbolic tangent models. There's 1 or 2 parameter logistic regression models or others. And in FACTS, and also in this presentation, we're going to use a 2-parameter logistic regression model. And generally, the way that CRM would work is based on the model and on the estimates, we'd have an understanding of where we think the MTD is. So say the model might think the MTD is 200 milligrams, and then that's where we would assign patients in the vanilla version of CRM. And then, of course, there's smarter things that you can do. Okay, just to sort of visualize what's happening in CRM, imagine that we're starting with a 2-parameter Bayesian logistic regression model, and say we're starting with a reasonably uninformative prior. So that's shown on the top right here. So the black solid line is just the point estimate of the toxicity for every dose, and then the gray area sort of gives the uncertainty around that. And I mean, one could argue that this isn't entirely uninformative, but it's fairly uninformative, I would say. But you could go more uninformative than that, or you could go more informative, depending on the situation that you're in. But anyway, let's assume you're starting with this prior. Then what happens is you're collecting data, and in this particular case, of course, you're collecting data on the smaller doses first. That's why you're seeing after maybe 6 patients or 39 patients, the gray area, so the uncertainty, this area becomes smaller as we get more data and as we sort of become more confident in our estimate of the dose toxicity relationship. And in theory, after every single DLT result of every patient that we observe, we sort of re-estimate the parameters. Of course, in practice, this might not actually be every single patient, but this might be after every week or so, whatever is convenient and whatever works. And then finally, what we do if we're done with the study, then we would, when it comes to actually choosing an MTD, we would choose the highest dose for which the probability of observing a DLT is close to the target toxicity rate. And by close, I mean that there could be different definitions. We could say, well, we always want to choose the dose that's below. We could also say we want to choose the dose that is actually close. And if that's sort of a little bit above, then that would also be fine. So anyway, there's different definitions here. And of course, this is quite simple, and this could be extended in many other ways. So that's sort of vanilla CRM. And then there's many possible adaptations to this. And there's a very good paper by Neuenschwandner et al. where they argue that many of these adaptations are sort of required to actually make CRM usable and feasible in practice. So some of these rules could be, some of these adaptations could be that we add so-called ad hoc rules. These could be don't skip those levels in escalation, or skip at most X those levels. What do I mean by that? Imagine that we started at 100 milligrams and we assigned 3 patients and we didn't observe any toxicities. Then it could be that the model after that thinks that MTD is going to be 150 milligrams as opposed to 125 milligrams, which would be the next step. And then if we don't have any rule in place that sort of says we can't skip those levels, then we'd assign the next patient automatically to 150 milligrams. Whereas we might want to disallow that. We might want to say, well, we don't skip those levels. And then that could be one of these ad hoc rules. Another ad hoc rule could be that we always start at the lowest dose. And I think that's a fairly common one. Maybe not the lowest dose, maybe the second lowest dose. Yeah. Then another possible adaptation is open enrollment, which I guess you might be curious about since this is the title of the presentation. I'll get to that on the next slides. Same with backfilling and front filling, early stopping rules, targeting toxicity intervals instead of a certain toxicity, or something that's called escalation with overdose control. So all of these concepts I'll talk about in more detail in the next slides. Okay, so let's start with open enrollment. Traditionally, what we would be doing in a dose escalation study is have something that's called cohort enrollment. So we'd say that a fixed number of trial participants per dose are assigned, and the trial is sort of paused until these results are available. So assuming we start with dose 1, by the way, on the right-hand side here, this graph are simulations from the motivating example I gave earlier. So dose 1 would correspond to 100 milligrams, dose 2 would correspond to 125 milligrams, and so on. So we might start here with assigning 3 patients to dose 1, and then if any new patients were enrolled in the study, they wouldn't get any treatment. They might wait, they might be told to wait until this cohort completes, and then maybe they'll be placed on a treatment, or they might simply be lost or rejected or not enrolled. And the next thing happens for the next cohort and for the next cohort and so on. And the other way of doing this is something that's called open enrollment. And by open enrollment, we mean that in theory, we continuously enroll patients and they might be assigned to, say, lower doses in the trial. So if we are, if you look at this graph, for example, if you look at those 5 over here, there were 3 patients or more than 3 patients assigned here. And then at some point, since we couldn't assign more patients to those 5, what we did was we assigned a new patient that arrived to those 4. And of course, what that does is it gives us more data and more information. And doing open enrollment is more than that. Doing open enrollment could also mean that at any dose that we haven't allocated to so far, we are more cautious than allocating to doses that we've previously allocated to. And this requires additional rules and risk management, but it can also offer many advantages. What do I mean by rules for open enrollment? So in FACTS, what we do is we have 3 Q concepts that govern how many patients without DLT results can be allocated at a given dose. So if you look at this example on the bottom right here, we're in a scenario where we've assigned 3 patients to dose 1. None of them had a DLT. We decided to escalate to dose 2. Now we've got 3 patients at dose 2, and you see this little X, meaning that the next patient that was enrolled in the study was not assigned to any dose. I mean, of course, in practice, this could mean that they're waiting. This doesn't have to mean that they're lost, but for the purposes of the simulation here, they're lost. So why did we not assign this patient to dose 2, or under which circumstances could we assign this patient to dose 2? Or if this was dose 6 and not dose 2, how sort of would the same thing have happened, or would a different thing have happened? And the way we do this in FACTS is we've got 3 Q concepts. There's 1 Q for uncleared doses. By uncleared, what we mean by uncleared doses is any dose for which we have not decided that there's enough information that we don't necessarily have to consider it safe, but we have to sort of consider it cleared. And that's something that you can set in FACTS. For example, you require 3 patients to have completed on that dose. That would be sort of, that would be what a 3 + 3 does in a certain way. So here we have set the queue length for patients on uncleared doses to 3, meaning there can only be 3 patients here, and any further patient that arrives is going to be lost while these patients are evaluating. Then we could have a queue concept of clear doses that are below the current MTD estimate and clear doses that are at MTD. And these might not be super meaningful at the moment, but we'll see them later in action, and then I think they become much clearer. This is how it would look like in FACTS, where we get to set these queue lengths. So in this particular case, we had maximum subjects without final results if dose is unclear is 3. We had maximum subjects without final results if dose is cleared and below MTD at 6, and max subjects without final results if dose is cleared and at MTD was also 3. And as I mentioned before, the concept of clearing a dose is separate from the queue lengths, in that typically we require a certain number of completers, but it could also be related to a certain maximum toxicity rate. Okay, what is backfill? So you will see that backfill is sort of instrumental in open enrollment. And imagine the situation here on the top right, where we've escalated up to dose 5. We've had 3 patients per dose and no DLTs so far. And you see with these little X's that when we were assigning to dose 3 and another patient showed up at dose 3, we were not assigning them at dose 3, and the same at dose 4. But now we're at dose 5. And this goes back to why I originally mentioned that in the motivating example, we sort of consider 175 milligrams to be the minimum pharmacologically active dose. And this would be dose 4 here. So dose 4 corresponds to 175 milligrams. And what we could do now is we could say, well, we've got 3 patients on dose 5, and we don't feel confident assigning more than 3 patients on a dose level that we haven't tested so far. But what we'll do with any further patient that arrives is put them on the dose below. And we sort of feel confident doing that because we've cleared dose 4 previously, and we've sort of got some belief that 175 is also pharmacologically active. So then what would happen if a new patient arrives is this patient would be assigned to dose 4 as opposed to being lost. And in FACTS, we sort of mark these patients with this star here. That means that they were assigned to a lower dose than the current escalation dose, which is dose 5. And again, this might be useful in certain situations where we just want to learn more about the dose toxicity relationship, but also where we want to learn more about efficacy and finding the optimal dose, because the alternative would be in cohort enrollment that this patient is simply lost or has to wait. Yeah, of course, with backfill, it isn't just a simple matter of saying, well, we do backfill or we don't do backfill. There's again, certain rules that we have to specify. So we have to specify a maximum number of patients that we do want to backfill, because if we have a budget of, say, 60 patients, we might want to not spend more than 20 of those on backfill doses and keep the rest for actual escalation. We also might not want to backfill to all of the doses. So in the example that I mentioned, if we think that 175 is sort of the minimum efficacious dose, then we wouldn't want to backfill patients below that. And we might also not want to backfill too far away from our current escalation dose. There's a concept that we call front filling, which is heavily related to backfilling, which is that we're backfilling to the front dose. What does that mean? I'll show you this example here. So if you remember before, we've specified that we want to have at most 3 patients simultaneously in the DLT period at the current escalation dose. That's what you see in the upper figure. There's 3 patients on dose 4 that do not yet have the results. But what happens if, say, the first and the second patient that we've assigned to dose 4, they had their outcome observed before the next patient arrives? Then at the time the next patient arrives, there's only 1 patient on dose 4 where we don't have their results. And we specified before with the queue lengths, with the open enrollment queue lengths, that we would in theory be happy to assign 3 patients simultaneously at the current escalation dose. So that would allow us to assign another patient to dose 4, as you see below here with this sort of other type of star. And that's possible because we were happy to have 3 patients simultaneously on the current escalation dose. And this is something that, in fact, we can just allow or not allow to happen. And of course, we might learn more if we front fill than if we backfill, but it's also more risky. So it's sometimes it's very difficult to justify the risk, but in certain cases it might be very useful to do. Okay, I know this is a lot of different concepts, but we've only got 2 left, so please bear with me. There's one that we call toxicity intervals and escalation with overdose control. Before, we said that our TTL is 30%, so our target toxicity level is 30%. And what we could do instead of just targeting this one value of 30% is we could target an interval. I mean, that's become also standard in other rule-based dose escalation algorithms. And then what we would do is, instead of calculate the posterior probability that a certain dose is the MTD, we would calculate the posterior that any given dose is within the target band. And related to that is escalation with overdose control, which here on the graph you can see on the bottom right. So in the middle here, we would have a toxicity rate from 0 to 1, and using these numbers 0.2, 0.3, and 0.6, we've sort of divided the space from 0 to 1 into 4 areas. We've divided that into a band that we would consider underdosing. We've got 1 band that we would consider the target band. And then we would have 2 bands. One of them would be the excess toxicity, and one of them would be unacceptable toxicity. And of course, how you set this is very specific to the trial at hand. But it could be very useful to specify additional rules to escalation, where you say you want to limit the probability to assign patients to doses where there's a substantial probability that it's within the excess toxicity band, or that it's within the unacceptable toxicity band. And that's exactly what escalation with overdose control is. So for example, here, what we've chosen here in FACTS, this lower box, this would mean that we do not allow patients to be placed on doses where we are where we have more than 20% posterior probability that it's that they're unacceptably toxic. There's also a possibility to make this stricter as the trial progresses. And then the last piece that we need, the last sort of set of rules that we need to make sure CRM behaves the way that we want it to behave, is so-called early stopping rules. On the right-hand side is again a screenshot from FACTS. And let's firstly look at this first option that is being set here. This is called required number of subjects near MTD is 18. What does near mean? There's a concept of near doses that we've defined above, where we say count as MTD doses differing from MTD by less than or equal to. And this basically means that when we calculate the probability that a certain dose is the MTD, we do not only count the probability of that particular dose, but we also count the probability of the doses that are being considered near. So meaning if we calculate the probability that, let's say, 250 milligrams is the MTD, we don't only take the probability of 250 milligrams, we also take the probability that 225 is the MTD and 275 is the MTD, and when we sum these three. And this might make sense if the doses that you're investigating are maybe at some point sort of close enough that you'd also think that they're not too pharmacologically different anymore, and whether it's 250 or 225 or 275, sort of you'd be happy declaring 250 the MTD. Another thing that we've set here, this is the option down here, is that we only want to stop early if the probability of being near the true MTD is greater than a certain threshold, and here we chose 60%. Yes, another thing that's on the very bottom here is that we have certain rules for when the model thinks that all of the doses are toxic, that we sort of stop very quickly and do not assign more patients. And there's sort of a minimum number of toxicities that we might want to see before we stop. And yeah, there's many more, and it can get much more complicated than that, even though that's already quite complicated. And another thing to mention here maybe is that these are early stopping rules that sort of we would include in the CRM, and we would include the CRM to suggest, and that's also when the simulations would stop. But of course, in practice, the DMC or SRC or sponsor may continue assignment even if the algorithm says to stop. Okay, that was a lot. Let me show you how we're sort of setting up this design in FACTS, and for that I'll just switch my screen share for a second. Can I just quickly ask someone to confirm that they see my Windows screen?
We can see it, but it's things look a bit small. If there's any way of getting the FACTS window bigger, that would be good.
Yeah, let me try that. I got that to work recently, but since it's a VM, it's a bit tricky. But I'm trying something, and then please let me know. Did that make it better or not?
Well, I've made it full screen. I can, yeah, the text is a little hard to read, but I can kind of see what's going on.
Trying one last thing.
Yeah, that seems.
What's going on here?
Ooh.
Yeah, that's the newest Mac update. That's terrible.
Huh.
How about that? Is that better? Is that bearable?
It's bearable. Yeah.
Okay. Yeah. Sorry, I've got no way of changing this.
If you're watching, you can zoom in on the window to see if it's small.
Yeah, thanks, Nick, and apologies if it's small. Okay. Imagine we've started the CRM engine in FACTS. Then this is where we start off. We'd start off in the study info tab, where what I've done is I've selected open enrollment as opposed to recruit in cohorts. And the first pieces of information that I entered are what's my maximum number of subjects, what sort of recruitment rate do I expect. Here I specified 1, meaning I expect 1 trial participant to arrive per week. I have a DLT period of 2 weeks. And then here are these 3 queues that we discussed before that I'm not going to get into more now. I'm just going to show you in an example because I think that's much more intuitive to see. But remember that these were queues for what are the maximum number of subjects that we allow without final results if the dose is uncleared or cleared and at or below MTD. There would be the option to specify 2 groups, but we're only interested in a single group. We're, in this example, not including cohort expansion. We might do that if we were actually designing this trial and this was a real trial. We might include cohort expansion, but we're not doing it here because it's quite complicated as it is. But we want to allow backfill. So that's this checkbox. And then as you can see here, there's 2 numbers that you need to enter. There's max study allocation for escalation, and then there's max study allocation for backfill. And you might wonder, well, these 2 numbers, they sum up to 80, but I only allowed 60. So how is that possible? So the way that this works is we might not do any backfill in the study. So we might allow backfill, but we might never get into a situation where we're actually doing backfill. So the first number here that we are maximum study allocation for escalation, I usually like to choose this as the same number of max subjects, because it basically means that if we're not doing any backfill, we actually can use all of the 60 patients for escalation. Whereas the max study allocation for backfill is sort of a safeguard that we're not going to use too much of our 60 patients for backfill. So meaning if we actually use 20 patients for backfill, there'd only be 40 left for escalation. But we might also be happy using them all for escalation and none for backfill if just the conditions for backfill are never met in the study. Next, what I do is I'd switch to the toxicity tab where I'm specifying these bands that we mentioned before. So here I specified a target band of 20% to 35%, but I'm not targeting this interval. I just specified these for the purposes of having escalation with overdose control. I'm still interested in targeting a single dose, which is a toxicity of 30%. And I'm interested in finding the dose that's below 30%. So the highest dose that gives me a toxicity below 30%. I've specified my escalation with overdose control, as mentioned above. So I don't want to allocate to any dose level where the probability of that this dose has excess or unacceptable toxicity is larger than 50%. And I don't want to allocate to any dose for which the probability of unacceptable toxicity is larger than 20%. So these are just some safeguards to not sort of assign too high doses to patients. In terms of treatment arms, I'm using explicit doses. There's also the concept of fine-spaced doses, which I'm not going to go into now, but it's much more convenient if you know that you've got many doses and they're all, say, 10 milligrams apart or something like that. But here I've specified the doses myself. So there's 11 doses and the dose strengths go from 100 milligrams to 350 milligrams in 25 milligram steps. We don't need variance in this design. So I'm switching to virtual subject response. I have a few scenarios, a few parametric scenarios that I specified. Where basically, let's start with the all toxic scenario. I've just specified these parameters in such a way that I see that even 100 milligrams would have a 50% probability of a toxicity. And from that point on, it just gets larger than that. So all of the doses here would be toxic. Then I have a scenario that I call all of them are safe. Meaning for the low doses, there's very, very, very low probability of a dose-limiting toxicity. And as we get to the highest dose that we're investigating here, which is 350 milligrams, we max this out at about 11% probability for a DLT. So yeah, all of them would be safe. And then I've got 3 other scenarios where they differ by what the MTD would be according to how I define MTD, which is the highest dose that gives me a toxicity that is below, a probability for toxicity that is below 30%. So there's a scenario that I call MTD 125, where 125 milligrams would be my MTD of the doses that I'm considering. And from that point on, they just become very, very toxic. And 100 milligrams is sort of quite safe, and this would be considered underdosing here. The same for 225 milligrams and 325 milligrams. So they just differ by how the true dose toxicity relationship is defined, and they always contain the dose that would be the true MTD. Okay, on the design tab, there's plenty of things that we need to specify. So firstly, we need to specify a thing that's called X-hats. That's basically how sort of these doses are standardized and mapped to the relevant probability space where I'm actually modeling. There's different things that you could try here. I've used this setting and it worked quite well, but you might sort of play around with these some more to see if they improve the performance. There's the thing that there's toxicity response, where I'm specifying my priors and where you can see sort of the prior that I'm using, which is pretty non-informative. So these dashed lines give the 95% confidence interval, and then the solid line gives the point estimate. And you can see this is a very non-informative prior. I'm not using prior pseudo subjects. So this is sometimes very useful to calibrate the prior to sort of give you desired operating characteristics, where you might say, well, you actually sort of have a prior belief in the strength of one patient that there should be no toxicity on the lowest dose, or you have prior belief in the strength of one patient that there should be a toxicity at the highest dose, or something like that, which of course, in fact, just changes the prior. But it's a nice way to sort of modify the prior as opposed to playing around with the parameters that can be sort of hard to interpret. There's a set of allocation rules that we need to specify. So we are using overdose control and additional rules. These are the ad hoc rules that I mentioned before that you might include in a CRM, where what we're doing is we allow incrementing by one in those levels. So meaning we always only allow one step up. So we only allow the step from 100 milligrams to 125 milligrams, and from 125 to 150, and so on and so forth. And if we made this number higher, then it would mean that we allow skipping certain dose levels, which in this particular case we didn't want to do. Then you can also specify here in dose clearing rules the minimum complete subjects on or near a dose that we need before clearing a dose. Clearing a dose means that we are happy to escalate, and this number is 3. Remember, I mentioned that we pretend to be in a situation where we're coming from many people being familiar with the 3+3 design, where you always need 3 patients on a dose complete before you would consider escalating.
So just to respond to a question that has been posted. So by putting 3 here as the number of subjects we want to see complete before we're happy, we count this dose level as being cleared, and we can escalate. This is kind of equivalent to the cohort size. So when you'll see in the escalation histories that we're now going to allocate subjects, and as soon as there's 3 complete, we can now escalate, and we have a choice as to whether, when we get to 3, we stop recruiting and allow and now don't allow patients in, or whether we carry on recruiting onto the dose, even though that's going to over-enroll to the current dose. But that may be useful, and it may be more useful enrolling those subjects than turning them away.
And on the study tab, we explicitly selected open enrollment rather than enroll in cohorts. So the question involves recruiting cohorts. So we chose not to do that with the CRM, but that is an option in FACTS if you know that you're going to have cohorts. But things like backfill don't necessarily go with the cohort recruitment.
Thanks, Tom. Thanks, Nick. Sorry, I didn't see the question. But yeah, thanks for answering it.
No, that's fine.
Yeah, one more thing that I wanted to mention here on the design allocation rule tab is that we can specify the initial dose that we want to start with. Here we chose dose 1 as our initial dose. And of course, there's good arguments to be made why we might not start with the lowest dose. So even if in practice, for example, even if you wouldn't want to, or if you're not interested in investigating doses below, say, 100 milligrams, it's sometimes useful as a safeguard to still manufacture those levels below that, just in case you get very unlucky on the first dose, so that sort of there's room for you to de-escalate and keep allocating and keep sort of learning and then maybe later escalating again, as opposed to sort of being stuck on the first dose and then finding you've got 2 out of 3 toxicities on the first dose, and that then your study is dead. So in practice, there's many reasons why it might be a good thing to not start with the lowest dose, but in this particular case, we did. Yeah, then we're getting to the backfill allocation tab. I've shown this before. Let's just talk through these numbers again to make sure we understand what they're doing. So there's no backfill to a dose if number of subjects on dose would exceed 9. That means, imagine we are in a situation where we escalated to dose 5, and say we've already assigned 6 patients to dose 5 before we're happy to escalate to dose 6. And now we're at dose 6, and we've got a couple of patients that we're backfilling to dose 5. We wouldn't allow more than 3 patients in this particular case to be backfilled to dose 5, because there were 6 patients previously, plus the 3 that we've backfilled gives 9. And we sort of don't want to overspend patients. And that's where sort of this number comes in. There's also the concept that a certain number of allocations via backfill cannot be exceeded. So it might be that we're assigning 12 patients to a given dose, but if 5 of them are backfilled, then the other 7 need to be sort of regular escalation patients. So yeah, just sort of not, both of these sort of go in the direction of saying we don't want to overspend patients on backfill. Then there's the concept that we don't want to backfill too far below the current escalation dose. This is where this number 1 comes in. So we're only interested in backfilling the 1 dose level below the current escalation dose. And in general, we do not want to backfill below dose 4. And the reason why dose 4 was chosen here was, I mentioned initially that there might be some prior belief that any dose below dose 4 is just not effective. And therefore, there's both sort of ethical reasons and also maybe monetary reasons not to assign patients in backfill to doses below what we think is the minimum efficacious dose. Yeah, then here's this checkbox that says we would allow front fill. And then there's a checkbox that sort of says that we count front fill subjects as backfill subjects. And that's important in conjunction with these limits that we set here. So this limit of 20 patients for backfill, the question is, should that include front fill patients, yes or no? And that's what we sort of specified with this checkbox. And we said that yes, this number 20 should also include front fill subjects. Then the last tab before we get to the simulations is the stopping criteria tab, where I talked about this before. We consider doses that are 25 milligrams above or below, we consider those to be near. And we would be happy to stop the trial early if we've got 18 patients near the MTD. Meaning if at any given point in time, we believe that dose 6 is the MTD, and we've got 6 patients on dose 6, we've got 6 patients on dose 7, and we've got 6 patients on dose 5. That means we've got 18 patients near the MTD, and then we'd be happy to stop. Of course, only if the probability that sort of either of these 3 doses is the MTD is greater than 60%. That's what we specified with this checkbox. Okay, I know that was quite a lot, but let's actually see some individual simulations here, because that might make some things a bit clearer. So
before you move on, Elias, there was a question about the stop. There was a question about the early stopping rules. Maybe it's going back to your experience working on like consulting projects with this, but will you talk about how you select stopping rules? Kind of can seem arbitrary by first look. So will you discuss what goes into that decision on when to actually stop the study?
Yeah, thanks. That's a very good question. I'm not sure I can sort of give a general rule here. I have a feeling that a lot of this goes back to maybe what the expectation of the team is and what they're used to in escalating. So it might be that you're trying to recreate a 3+3 design as closely as possible, or there might be other arguments to be made. But yeah, it's a bit tricky here to sort of give a general recommendation. I have a feeling a lot of designing CRM is to do with looking at the individual simulations and just making sure that they behave sensibly. And you might sort of end up in a situation where you have a maximum sample size of 60, but after 30 patients, you are just assigning patients to the same dose because your estimate of the MTV didn't change. You just stay at the same dose and you would assign 30 more patients to this dose. So of course, that's not very useful. And then sort of that might inform how you're tweaking your stopping rules. I know this is maybe not a sort of a comprehensive answer, but I hope it gives sort of an idea.
No, I think that's great. And there's a question about seeing some results. So I think people are going to be interested in seeing some individual trials where there's escalation, de-escalation, things like that all happening.
Yes.
Yep.
Yes, no, great, thanks. Yeah, that's sort of the next, that was the next step here. So let's look at some simulations of the scenario where we know they're all toxic. So what we can do here in FACTS is we can click explore results. We can say show highlighted scenario graphs. And then the one that I really like is the per sim allocation history. The color here in the background would just mean that we know that all of the doses are toxic. So that's why all of this is all shaded in red. And if one of them wasn't toxic, this might be shaded in green or something like that. So I'm just going to get rid of show truth. That's what the color is for. And then I also like to space interims equally. That just means that we are sort of the x-axis gets transformed from actual weeks into just being every single tick is a patient. So one example simulation that we have here is we started on dose 1, we assigned one patient, we assigned another patient, and we assigned another patient. And then the next patient that arrived, so there's two things that happened here simultaneously. The first thing is that there was a patient that arrived that couldn't be enrolled in the study because there's sort of 3 patients on dose 1, and we do not allow front fill on doses below dose 4, meaning we are sort of stuck with 3 patients and we need to wait until they're enrolled. If this was dose 4, since we would allow front fill starting from dose 4, this patient that is lost here, that might actually have been front filled, but we are not at dose 4, so this patient is lost. And then the second thing that we see here is that this first patient that we assigned here had a DLT. So that's the red dot here. The second patient also had a DLT, and what we see is the model at this point is ready to stop. There's 2 toxicities that we've observed, and the model at this point is sort of sufficiently sure that all doses are toxic. So we're just waiting for the 3rd patient to be enrolled, and then we stop. So in other words, what this means is we've somewhat recreated a 3+3. So because in 3+3, you'd also expect that if you see 2 out of 3, you stop. And we've made sure that by the way that we've sort of set our prior and we've calibrated our stopping rules and everything, that we sort of see the same behavior. And from my personal experience, that's quite important when you're showing these to clinicians because they might expect the 3+3 behavior even if we're doing CRM. So that's, in this case, I'd say that's good. I mean, we also know that all of the doses were toxic and that's the right decision, but also stopping after 2 out of 3 DLTs, I think is reasonable. Let's look at a scenario where all of them are safe. So we expect to escalate to the top. again, I'm looking at the per sim allocation history. I'm getting rid of the truth here because it's all blue. It's not very informative. I like to space interims equally. And let's see the behavior here. We're assigning 3 patients to the first dose, and then we are waiting. We're waiting for these 3 patients to be observed. That's the same sort of behavior as we'd expect if we had a cohort size of 3, because remember, we're only doing backfilling and front filling starting at dose 4. Then we're losing a couple of patients because we can't assign them to a dose. And after we've seen 3 out of 3 non-toxicities, we're happy to escalate to dose 2. Then the same happens at dose 2. We assign 3, none of them are toxic. We're happy to escalate to dose 3. The same happens here. 3 patients are assigned, 3 of them are non-toxic. In the meantime, we lost a patient, and now we're going to dose 4, and that's where sort of the interesting stuff is going to start. So we've got 3 patients assigned to dose 4, and by the time the next patient arrives, we have already observed results on the first 2 patients that we assigned to dose 4. So we're happy to front fill this patient. Remember, our queue length of patients on uncleared doses that can be in the DLT period simultaneously is 3. And by the time this patient arrives, these 2 have completed. So there's only 1 patient in the DLT period at this point in time. So we're happy to front fill this patient. By the time the next patient arrives, the 3rd patient here had their outcomes observed, and it was also a non-toxicity, meaning for the next patient that arrives, we're happy to escalate to dose 5, while there's still this 1 patient on dose 4 where we're waiting for the results. This continues. We assign 3 patients to dose 5. And then what happens is the next patient that arrives before any of these 3 had their outcomes observed. So we're now in backfill territory, meaning we're happy backfilling. We're happy backfilling starting at dose 4. So this patient, instead of losing this patient or putting them on the waiting list or something like that, we're actually assigning them to dose 4, where we believe that this is already an efficacious dose. And this patient, of course, will not only help us estimate efficacy, but it will also help us estimate the dose toxicity relationship later. Yeah, so this pattern continues. We go to dose 6. We have a front fill patient. At some point, we escalate. And now I'm just going to sort of jump through this to sort of show you how we would have some front fills, some back fills, and we'd escalate to the top dose, and then we'd stay there until our stopping rules are reached. So the stopping rules here are a mixture of that we want a certain number of patients near this dose. So this was 18. So we want at least 18 patients, both on dose 10 and on dose 11. But we also want to sort of be sufficiently sure that, that's the MTD with this rule of 60% that we also chose. And maybe in the interest of time, just one quick example for MTD of 225, where we're going to see a little bit of up and down. Here I'm going to leave the colors, so we see that doses 1 to 5 are sort of underdosing. Dose 6 would be the target dose. Dose 7 is sort of excess toxicity, and then everything above would be sort of unacceptable toxicity. And I'm just going to sort of do this a bit quickly and narrate through this. The first part sort of is the same. We've seen this before. We assign patients. Starting at dose 4, we'd be happy to front fill and also backfill. At some point, we start seeing toxicities, and notice how until this point in time, our model thought the MTD is dose 11. So had we not had rules in place that said you can only ever escalate to the next dose, you cannot jump those levels, or at least you cannot jump 5 dose levels at the same time, the model here would have decided to assign patients to dose 11, which would have been terrible, of course, because we know that this is extremely toxic. But we had these rules in place to only escalate by 1 stop. And as soon as the first toxicity is observed, the model sort of registers that immediately and now thinks that dose 6 is the MTD. So that's sort of this red triangle that we see drastically drop after observing 1 DLT. We front fill some patients here. We do decide to escalate after seeing 2 more non-toxicities on dose 6. And then sort of after observing toxicities on dose 7, we jump back down to dose 6. And then we just stay on dose 6, we backfill to dose 5, and eventually, after about, 38 patients, we're happy to stop the CRM because our stopping rules are reached. We've got 18 patients near dose 6, so that counts patients on dose 7 and on dose 5, and we're sort of sufficiently sure from our posterior probability that dose 6 is going to be the MTD. So time is running out a little bit. I just wanted to ask Tom and Nick, are there any urgent questions, or can I sort of go back to the slides and finish up?
Yeah, no questions. We've been answering them as they come in.
Oh, great.
Via
Thanks
text.
a lot. Great. Thanks a lot. Okay, let me just give some closing remarks. We've looked at this. So the first thing that I would do if I was designing this CRM is look at these individual trajectories and just look if what the CRM is doing is sort of sensible. And what do I mean by that? Would it suggest escalating after we've seen 3 out of 3 DLTs, or would it suggest to not escalate after 3 out of 6 DLTs? Then we might have to tweak the prior or include pseudo subjects or have a look at our escalation with overdose control rules. Would we assign half of our patients just to the same dose, even though the estimated MTD doesn't change? Well, that might tell us we need to tweak the stopping rules. Do we have very fast recruitment, and do we either lose a lot of subjects or do we backfill too many subjects? Well, that means we need to have a look at our backfill rules. Are we assigning too many patients to previously untested doses? Well, this would mean we would have to tweak our open enrollment queue lengths, because there we can specify that we want to have at most 3 or 4 or 5 at the same time, or even 1 or 2. Are we jumping back and forth between 2 relatively similar doses for a very, very long time? Again, we might have to tweak the stopping rules and consider a certain threshold being near. We've seen these are just individual simulations. I'm going to skip the operating characteristics part here, but of course, after looking at the individual simulations, we'd run them 1,000 of times and look at the operating characteristics. And generally what we do here is just, again, make sure that this behaves favorably. So in a case where all of them are safe, we want to choose the highest dose as our selected MTD. In a case where all of them are toxic, we want to make sure that the CRM also identifies all of them as toxic. And in the case where one of the doses in between is the MTD, we want to be sure that our CRM with a high probability detects this dose as the MTD, or at most maybe the dose above and the dose below. And that's generally what we see here. Yeah, and if this was a real trial that we were designing, I mentioned a couple of these things before, we might tweak dose standardizations and the prior to see if we can further improve the operating characteristics. We might think about skipping doses, maybe 1, maybe not more than 1, but we might think about skipping 1 dose per escalation step, or have a run-in. We might simultaneously simulate efficacy and also search for the minimum efficacious dose, because that's what we would want to do for Project Optimus. We might consider expansion cohorts, more scenarios, more recruitment rates, and all of this is doable in FACTS. So to sum up, there's many of different adaptations that CRM offers, and all of them require calibration. But after you've calibrated everything, it works really well also for extreme scenarios. The FACTS CRM engine is highly customizable. There's plenty of features that we maybe talked about theoretically, but I haven't shown in FACTS, that FACTS can also do. Some of the features that I showed today are sort of previews for what's going to come in FACTS 7.1. And there's more efforts to include also other rule-based dose escalation methods into FACTS, so we can compare them all in FACTS. And as always, if you have questions, feel free to reach out to us. I hope that wasn't too much. I know it was a lot, but I hope you still learned something and are maybe interested in trying out a CRM in FACTS soon. And yeah, hope you have a great rest of the day.
Yeah, thank you very much, Elias. So there will be another case study next week on I believe the ENRICH trial. And any questions, as Elias said, don't hesitate to reach out to us at facts@berryconsultants.com. And we'll be sending out an email to those who attended with a link into the recording.
Thanks, Tom. Thanks, Nick.